lam yalid wa lam yulad wa lam yakul lahu kufuwan ahad. So I think today my presentation is on metabolically associated steatotic liver disease and the clinical care pathway. I will just briefly discuss how should we work up and work for a patient coming with steatosis, because so many patients, they're coming with just fatty liver diagnosed on ultrasound and then they don't know what to do. And I think, as we call diabetes as the mother of all diseases, I think nowadays the insulin resistance is even mother of diabetes and all the metabolic diseases. So this is a very common topic, and just want to share the clinical care pathway and how should we work up for the patient. So we'll just talk about nomenclature change and the clinical care pathway and brief management. This is, we all know, the fatty liver disease. Major group is steatotic liver disease. Any patient coming with steatosis on liver, on any imaging modality, we all know that plus any of these criteria, either BMI is more than 25, and Asian ke liye now it's bad news because 23, or waist circumference more than 90 in male and 84 in female, and then fasting glucose more than 100 and random postprandial more than 140. Our patient diagnosed with diabetes, our patient on treatment of diabetes, and then blood pressure either systolic more than 30, diastolic more than 85. Our patient on antihypertensive drugs, then triglycerides more than 150 and HDL either less than 50 or less than 40 in female. So any one of these criteria plus steatosis on liver disease. So this is so common that I think every three out of three, everyone is having this. So this is the prevalence. I think we are here. So almost 33% prevalence, 30 to 33. So very common and very simple. This American Gastroenterology Association, Mr. Fasiha Kamal and et al., they presented the algorithm. You will have to identify patients at risk, like 2 or more metabolic risk factors, or type 2 diabetes, or steatosis on any imaging modality. And then you'll have to, the step 2 is history and body examination, alcohol intake, CBC, liver functions. And then step 3 is non-invasive testing for fibrosis. Like FIB4, you will need only ALT, AST, and platelet count and age for that. And you just add all these in the FIB4 calculator in the mobile, and it will be calculated. If it is less than 1.3, there's no need to worry. Patient is very low risk. But if it is between 1.3 to 2.6, this is intermediate risk. Or if it is more than 2.67, this is high risk, then you will need further investigation, and maybe you will have to refer to the hepatologist or endocrinologist for liver biopsy and further workup. So most of the patients, they fall in either low risk or intermediate risk. But if we are able to, as a primary care physicians, if we are able to calculate and work accordingly, we can manage many of the patients. So this is, I will just give an example of a hypothetical patient, a 50-year-old female, 5 feet 4 inch, BMI 37, postmenopausal, hypertensive, diabetic, and feels well but a little tired. AST, ALT, these values are here, and US ultrasound revealed hepatic stenosis. So this is a common scenario. Most of the patients coming to our clinics in this, and doesn't look bad, but when we will act according to the criteria, if we calculate the FIB4, it's risk factors, obesity, hypertension, type 2 diabetes, then steatosis on ultrasound, elevated AST and ALT, and these are the metabolic risks. Metabolic risk factors and risk factors for MAFLD criteria are almost same. We can see central obesity, either be obesity, high waist circumference, high TG, either be high TG, low HDL, hypertension, pre-diabetes. So, out of 5, any 1 plus steatosis, so patient is high risk. Now, if we'll take this patient may have ALT and AST is also high. So if we'll calculate her FIB4, it comes out to be 1.9. So this is, she is in intermediate category. And Renee, this is a very readily available. At FIB4 you can calculate anytime in the clinic. And it has a very high negative predictive value. Means that if it is normal or it is negative, then there is a very good chance that the patient doesn't have cirrhosis. And FIB4 less than 1.3 exclude advanced fibrosis with negative predictive value of more than 90%. So this correlates very well with clinical outcomes as well. So her FIB4 is 1.9, it means it is into the intermediate risk. Now you will have to do another either VCTE or fibroscan, जिसको old कहते थे, for another non-invasive modality to check the liver stiffness. So liver stiffness measurement करेंगे. If it is less than 8 kilopascal, this is again low risk category. You will have to follow up after 2 to 3 years. And if it is between 8 to 12 kilopascal, then this is again intermediate risk. You will have to refer to hepatologist for liver biopsy or MRE, or you will have to monitor more frequently. And if it is more than 12 kilopascal, then you will have to, this is a very high risk patient, you will have to immediately refer to hepatologist for either MRE or liver biopsy and further management. So we calculated VC, it comes out to be 13.3. So see, this is more than 12. So this is high risk. A normal looking female patient coming routinely to our OPD, but when we calculated its parameters and its risk score, is turned out to be high risk. So this patient needs very extensive workup and treatment immediately. Otherwise, she will go into liver cirrhosis and then ultimately maybe hepatocellular carcinoma. So another test is if we don't have VCTE, then we can have another test that is called enhanced liver fibrosis. This is blood test based on these hyaluronic acid, P3NP, TIMP1. And if this is normally less than 7.7. So if this is more than 7.7, again, or 7.7 to 9.8 or more than 9.8, then again we'll have to send the patient for hepatology. For liver biopsy, if it is less than 7.7, then again patient is low risk, and you can advise lifestyle modifications and weight reduction, and patient can be managed by the primary care physician. So VCTE or ELF, these are two tests which can be done to further risk stratify the patient. And then if it is high risk, then you will have to do biopsy, and if there's a 0 to 1, you can reassure and re-evaluate 2 to 3 years, and then if it is 2 to 3 or more than 4, then you will have to treat on the lines of cirrhosis. So this is the message. My message is that most of the patients, I think that 90% of the patient will fall into low risk or intermediate risk, and they can be converted back even from the intermediate risk to low risk by reducing lifestyle changes and reducing weight and adopting healthy exercise and lifestyle and diet. Because once the patient develops cirrhosis, then we all know either she or he will have to have liver transplantation, or God forbid, to develop hepatocellular carcinoma, then the game is lost from our hands. So we should try to keep the game in our hands by early detection and early sensitization of the patient. We don't just give importance to slight raises ALT and AST, but if you act systematically, this can be very risky and this can be very dangerous. And patient can be early, it can be detected. So these are few modalities we have already discussed. Blood markers, like transaminases, transaminases, platelets, bilirubin, INR, albumin, then APRI score, FIB4, MAFLD fibrosis score. These are specialized tests. So These are the blood tests, and these are the VCTE, and either SWE, a 2D, SWE, MRE, then these are depending upon the availability. But as I said, even you need one FIB4, and then the another one liver stiffness के लिए कोई भी आपको maybe fibroscan or VCTE or even ELF, whatever is available. So this depends upon the cost as well as availability. So you can tailor it accordingly, but you cannot and you should not miss the diagnosis of this steatotic liver disease. So this is about the treatment plan. Once we have, first of all, we have to identify the high-risk patient, then do the workup. And now if we are able to categorize the patient at low risk or intermediate risk, then we'll have to do its lifestyle changes. This is low risk, intermediate risk, and high risk. We'll have to do lifestyle changes for everyone. And then weight loss for almost everyone, healthy lifestyle. And then pharmacotherapy for NASH. So this MAFLD, when the liver, when there is inflammation in the liver, then it is called MASH. So MAFLD is when up till only there is a fat deposition in the liver, but there is no inflammation. So when there is severe inflammation, then MASH. So even pharmacotherapy for MASH is not recommended in low risk group. You will have to only, we will be talking a lot about resmetirom and the new drugs coming. But we'll have to individualize the patient because every patient will not need every drug. Even these fancy drugs are not required if the patient is low risk. And CVD restriction इसमें करेंगे. अब only intermediate and high में जो NASH अगर develop होता है, तो then there is a role of all these new drugs. Then diabetes will have to care in any case. So as I said that basically the insulin resistance is the mother of all diseases, all the metabolic diseases, including type 2 diabetes. So you will have to adopt healthy lifestyle, healthy diet, and which is our motto of our PSIM as well. I was very happy that in spite of so much hectic schedule, we are always we arrange yoga sessions and we do a route to health walk and all these things, and that is the beauty of this society, that we basically want, and we are doing health and dealing health and science side by side. Actually, health and science I think is the same. So this is just fat, this is fat plus inflammation, this is fibrosis and then cirrhosis and then all these things if we don't. And the good news is that we can revert. I don't know, cirrhosis so difficult, but from fibrosis you can return the things and revert the things back, but timely by action by the physician as well as by the patients. So target treatments for FDA approved indications or comorbidities of are like metformin. We all know it is a universal drug and always increases insulin sensitization, reducing insulin sensitivity. It's a very good drug. Then vitamin E, pioglitazone. It is also insulin sensitizer, but in obese patients, it can cause weight gain, so it can be avoided. Then GLP-1 receptor agonists and SGLT2 inhibitors and statins. So all these drugs, these can be tried. These are the drugs we all know. This pioglitazone can improve cirrhosis, NASH resolution, possibly fibrosis improvement, but not sure. And vitamin E ka kuch role, but mainly comes the role of all these liraglutide, semaglutide, and tirzepatide. We are going to discuss in detail today. So these drugs are supposed to improve steatosis and maybe some resolution of NASH. And obviously type 2 diabetes भी अगर साथ है तो these are the essential and these are the very good drugs. And then I will just touch upon this this MAFLD and MASH has a very complex this mechanism. So only few drugs, trial was or obticolic acid that was banned. Then these are the drugs. Now we have thyroid hormone receptor beta agonist, resmetirom. This is available now. This drug has proved to be maybe reversing fibrosis and maybe of some effect in cirrhosis and as well. But all these other drugs, I will not go into the detail. These are the drugs in the pipeline, FGF21, and then PPAR, alpha gamma agonist, Lenny, Fibronor. Maybe anytime this is in phase 3 trial, then these can act on different mechanisms. So we'll not go into the detail. I think I have finished in time. So thank you very much.